Good afternoon, everyone, and welcome to session 8 of our Skilled Nursing Facility Antimicrobial Stewardship Collaborative. I will be your host today. My name is Jessica Zering, and I am the Antimicrobial Stewardship Pharmacist here at the Washington State Department of Health. Today, I'm going to be talking to you about transitions of care. Rather, this is actually going to be a conversation about antibiotic timeouts with the framing of transitions of care. With that, let's get started. Why is this important? The CMS State Operations Manual actually has a reference to transitions of care listed in the antibiotic stewardship section. This is the exact wording from the State Operations Manual. It states the antibiotic stewardship program protocols should incorporate monitoring of antibiotic use, including the frequency of monitoring review, monitor review response to antibiotics, and lab results when available to determine if the antibiotic is still indicated or adjustments should be made, e.g., timeout. When the resident is new to the facility, when a prior resident returns or is transferred from a hospital or other facility. What is transitions of care? This is likely a topic that doesn't need much in the way of introduction. Ultimately, it takes place when a resident is transferred between two sites of care, most commonly the hospital and facility, or vice versa. There are many challenges with transitions of care present. I used to work in the acute care setting and have observed a lot of challenges from that standpoint. Ultimately, for nursing homes and other long-term care facilities, there can be a lot of challenges in terms of lack of immediate culture and susceptibility report results and antibiotic prescribing rationale present, and just an overall lack of records immediately available. Additionally, transitions of care can and does sometimes take place after hours, which provides just further challenges. With that, we'll go ahead and transition to antibiotic timeouts. Again, we're going to frame this discussion from a transitions of care perspective. Let's revisit that CMS State Operations Manual paragraph. This time, though, let's pay attention to the bolded text, which states monitor review response to antibiotics and lab results when available to determine if the antibiotic is still indicated or adjustments should be made, e.g., antibiotic timeout. What is an antibiotic timeout? It is a provider-led reassessment of the continuing need and choice of antibiotics when the clinical picture is clearer and more diagnostic information is available. Commonly going to take place about 2 to 3 days post-culture and susceptibility. However, it can take place as often as feasible for your facility. That could be a couple times a week, it could be once a week, it could be more frequently, depending upon your resources. Simply put, a timeout is a safety check to ensure quality improvement. It is a checklist. That is the most common way to think of antibiotic timeouts. However, you can also do a timeout with whatever format works for your facility. When I worked in the acute care setting in my hospital, I used a word table to do something that we do in the acute care setting that is similar to a timeout. Antibiotic timeouts are also action-oriented and involve direct action interaction with a provider as well to share your findings that you made during the timeout. They're also adaptable to clinical settings and often adaptable and flexible, hopefully for facility-specific needs. A little bit of the history now of checklists. There was a book written a while back called the Checklist Manifesto, which talks about how many industries use checklists. The airplane industry or airlines use checklists, surgery departments use checklists. Medicine is very complex. To err is human, and checklists can help us. The amount and complexity of knowledge has exceeded our individual capacity to remember or apply them correctly and consistently. We lack certain skills, knowledge, or experience. Think about, for example, someone who is new to your facility, a new infection preventionist. A checklist can help them as they're acclimating to your facility. It can also help a more experienced person as well, who maybe is not used to the role that they're currently in. We fail to apply our skills and knowledge correctly. We forget to lose focus when distracted or overwhelmed. Checklists can help us remember those important pieces of information. Also prevents us from skipping steps or taking shortcuts as well. There was a study done that was published in the New England Journal of Medicine that looked at a surgical safety checklist to reduce morbidity and mortality in a global population. This is a portion listed here of the 19-item World Health Organization Safe Surgery Checklist. Ultimately, the study looked at the impacts of a checklist or timeout performed before surgery. Based upon their results, they found that they reduced mortality from 1.5% to 0.8% and complications from 11 to 7%, indicating again the importance of checklists. When you're creating a checklist, what should you put on it? When you're doing a timeout, some potential targets could include whether or not it's the right diagnosis, whether or not it's the right drug. Perhaps that's something that can be done in cooperation or collaboration with your consultant pharmacist, perhaps with a provider champion. Is it the right dose, route, or interval? Another item that can perhaps be done in conjunction or in collaboration with a consultant pharmacist. Is it for the right duration? Other potential targets and thoughts to consider as you're creating your timeout. Is there an infection or indication documented for the antibiotic? Do we need to stop or adjust the antibiotic based upon the presence of clinical improvement? What duration should we pick? And is there another action needed? I have some templates that I will show you here shortly that will help you in terms of creating your checklist. When creating it, think to yourself about the questions that you want to answer. What is your target? Your target might be residents who are currently present in your facility, plus those residents who are being transitioned from an acute care setting back to your facility. It could be newly prescribed antibiotics as well. When to perform the timeout? This can be very individual and depend upon your institution's resources. Do you have the resource to do it every 40 to 72 hours when culture and sensitivities come back? Or perhaps maybe weekly is more feasible when the provider is available. Who should be involved? Is this going to be a multidisciplinary process, or is it going to be a single individual who is performing this timeout? Are you going to be the data collector, or is the prescriber perhaps going to be involved in some way? Based upon these and many other considerations, create your antibiotic timeout. I will show you two excellent templates that we have found that can get you started. One of them is from Minnesota's Department of Health, and one of them is from Nebraska ASAP. I will admit I'm a bit of a fan of the one from Minnesota because it is not only very general, but they target very easy and feasible red flags and actions to take that can support you with your timeout process. The Nebraska ASAP timeout that I have listed here is a UTI SBAR that focuses on the Loeb criteria specifically and can provide some more specific guidance for very selective syndromes. Let's go back though to that 72-hour antibiotic timeout on the left-hand side of the slide there. Looking at from top to bottom, of course, you have the demographics on top. You also have the rationale for is the antibiotic prescribed. It has little check boxes for whether or not the culture is present, whether or not diagnostic imaging is present. They also ask if the resident meets Loeb criteria. Determining Loeb criteria, whether or not someone meets that, may be a bit more challenging for someone who is transitioning from acute care back to the facility. But this is an excellent area of focus for folks who are being diagnosed in-house within the facility itself. What are the risk factors? What are some concerns as well? Is there a wound? Does the resident have diabetes? Do they still have symptoms? This is important to determine if there's clinical improvement occurring on an antibiotic. If a resident has been on an antibiotic for 3 days and they still have symptoms, perhaps that's something that the provider who is on staff today can address and monitor, regardless of if they are within the facility or if they're transitioning from that acute care setting back. Going down now to the red flags. Again, I love these red flags because they are fairly simple and feasible to spot. When you look at a resident either coming to you back to you from an acute care facility or within the facility getting diagnosed itself, is the antibiotic being ordered for more than 7 days? There's a lot of literature available now that shows us that shorter is better. ultimately. Most durations of therapy for many common infectious disease syndromes are not going to have durations greater than 7 days. Now, of course, there's always exceptions to this, but the more common syndromes, especially uncomplicated urinary tract infection, are going to be for less than 7 days. Therefore, this is a really great red flag to look at when you're doing your timeout. Is the antibiotic inconsistent with organism sensitivities? Let's think for a second, for example, of a urinary tract infection, a true confirmed one in which a urine culture is obtained. Perhaps that resident is currently being treated with sulfamethoxazole trimethoprim, and you get that culture result back and you see the big old R for resistant on the culture report. That's a great red flag. Now, culture and susceptibility reports can be heavily nuanced. However, I would encourage to try to focus on, in order to enhance feasibility, focus on as simple as possible, essentially. If the antibiotic on that the resident is on is matching the culture and susceptibility on the report. Of course, if that resident is not improving regardless, that is certainly always reason to update the provider. There's no stop date on antibiotic order. A great example that I've heard of from nursing homes specifically is that of nystatin powder. Oftentimes nystatin powder will be ordered, but there will be no stop date on it. Essentially, it's just PRN infinity is the SIG. There should always be a stop date on every antibiotic, or in this case, this is also antifungal, as nystatin is an antifungal order. This is also a great red flag to look for. More common, I'd say, within the facility than for those who are transitioning from acute care back to the facility. If you're transitioning back from acute care, you're going to just about every time have a stop date. No labs are available. Perhaps there was no labs performed in the resident for feasibility reasons or whatever. That can certainly be a red flag to contact the provider and ask, do we need any labs? There's also some other red flags and some actions to take. Very, very, again, feasible actions. Inquire about lab diagnostic result. If you don't have culture and susceptibility, for example, for a resident who has come to you from the acute care side, whether it be ER or an inpatient stay, perhaps contacting that facility and asking them to fax you the labs is a excellent action to take. Remove the catheter, update the provider, notify nurse manager and facility supervisor, or no action is needed. Now looking at the right-hand side of the screen here at the Nebraska ASAP SBAR, this is, again, a fabulous resource as well. This is going to be syndromic specific. However, you can see that it's a lot more focused on urinary tract infection here and gets very specific for steps for that. If you have a singular target in your facility, say it's urinary tract infection, then I would say this would be a great resource for you as well. In conclusion, for transitions of care, one of the big challenges, as I said earlier, is those records, getting those records, having access to those records. Sometimes there is a very significant delay in getting those records or them being available. One consideration thought is to integrate requests for records into that antibiotic timeout. Now, I do want to point out that I am sharing my perspective as a clinician. There are certainly MDRO notification processes that may be much different and may have other records request components integrated in them. Always follow whatever processes are best practice when it comes to infection prevention and obtaining records. This is my clinical viewpoint. Additionally, if you're noticing a pattern where a certain acute facility is sending back residents on unnecessary antibiotics, one consideration is to reach out and ask to have regular meetings with them. I worked for an acute care facility that did have a forum like this where they would meet regularly with the facility that was in town. This is a good forum to perhaps share barriers and discuss solutions. You can also ask to meet with the emergency room medical director as well. Again, to share the concern and ask how you can work together on this opportunity. Lastly, here I have a QR code for folks who are looking to obtain the certificate, make sure that you get your attendance verified. Go ahead and just point your phone at that QR code and scan it. With that, I would like to thank you so much for your time and attention today, and I look forward to seeing you all next month. Take care.